If you notice, I got new glasses.
I like it. I know, but Suzanne and I both got our hair done this week and both basically have the same outfit on and we haven't talked. Okay. So we've let people in. Perfect. Good Friday morning / afternoon, depending on where you are. I'm going to welcome everyone to this month's Next Level kind of casual Friday, kind of hot topics conversation. We have, besides me, obviously recovering from a cold. Thankfully, thankfully I've got Suzanne, but we have our very special guest, Jeff Davis. Jeff is a very well-known attorney, very well-known 340B expert in this space. He is with Bassberry and Sims. He's had a long history in the program and has been a really good contact and colleague and friend of RxX's for forever. And so today we're going to be talking about all things with the rebate model, proposed rebate models. We're going to go over questions, answers, all of that. Is there anything kind of to start? Anything else, Suzanne, Jeff, you want to say hi or we want to get into it?
Happy to jump right in.
Perfect. Okay. All right. And everyone can see the slides too, correct? All right. Okay. So I'm going to kind of just jump a little bit in, and then I'm going to let Jeff take over from here. That and I'll also mention that we can send out Jeff's very well written, very eloquent memo that he wrote from his firm that kind of was the inspiration for this discussion. But as everyone knows on the line, that 340B has always been an upfront discount, unless you were an ADAP that had a rebate model, which was for all sorts of other reasons. It functions basically like an insurance program, not like a clinical kind of encounter or visit. It's always been upfront. And so over the last, since the summer, this idea of this rebate model has come in full force, and we've got 4 manufacturers that are pushing for it, probably with others to follow. So Jeff, I don't know if you want to kind of take it from here and talk about what are these models looking for, and what are, like, who are the players?
Yeah, I'm happy to chime in on that, and thanks for having me. Happy to be here today. I'm sure I know many of you on the line, and for those I've not met, I'm glad to be connecting with you. The way that I've been thinking about what these manufacturers are looking for, it sort of seems innocuous on its face. Well, you're still going to get access to the 340B price. You're just going to get it through a rebate instead of an upfront discount. What's the big idea? What's concerning about that? And we can talk about some of the specific financial and operational concerns, but it is a really, really different way of getting access to the benefit of 340B that has never been used before. And this program has been around since the early 90s, right? Congress enacted 340B in 1992. And from day one, it has always worked for hospitals and really for all covered energy types except for one that I'll mention in a moment, as an upfront discount. When you go to place the order for the drug through your wholesaler, you get to buy it through at a 340B price. You have a 340B price catalog from your wholesaler. You place the order, you receive the shipment, you spent the 340B price. Obviously billing it to a payer and then generating reimbursement from the payer helps you generate that spread. But even just buying the drug at the lower price is savings, right? If you're giving a drug to an uninsured patient, you're out that money. And so being able to buy it up front at the lower price means you're losing less than you otherwise would have lost. That's always how the model has worked. with the exception of one specific covered entity type that kind of just operates differently. And so what these 4 drug manufacturers have proposed is moving to a wholly different way of getting access to the 340B benefit, where instead of buying a drug at the 340B price, you will no longer have access to a 340B price catalog through your wholesaler. And instead, you'd have to buy the drug at a list price, a wholesale acquisition cost price, which can be substantially higher than the 340B price, and then submit information on the back end to the manufacturer through their vendor's, online platform, and wait for the manufacturer to validate that that claim is in their mind 340B eligible. And only then will they give you access to a refund on the back end to kind of make it as if you purchased the drug at the lower price.
Yeah, and I think a couple of just comments on what you said, Jeff, that I think it's just really important for everyone to know is the chargeback process with wholesalers is so, has been so long established that then having this rebate model really cuts them out of the process as well. So I think that's it's just something to put in everyone's minds that this is disruptive to multiple stakeholders. And so that's why we're probably going to see wholesalers trying to come up with solutions that keeps it non-rebate as well. It's basically, trying to cut out both wholesalers and, in effect, and I've talked a lot with the folks both at Calderos and BRG about what, like you're kind of doubling, you're duplicating the efforts that are already going on with the accumulators and the split billing vendors. So, what are you really accomplishing through this? So I think that is, just kind of an interesting concept. And I know, yeah, go ahead.
Go ahead, Melanie.
I was just gonna say, so like with being our the lawyer on the line. So when they say, like, what can you talk about? Like, what are the cases kind of about, like at their core? Like what are the wholesalers saying? What are the manufacturers saying versus what is HRSA saying back?
So in terms of the 4 specific manufacturers that have proposed or put forward a rebate model, they're not all the same. First of all, the actual what they're proposing is very different, but also the way they've gone about it is different as well. So for 2 of them, J&J and Sanofi, they've actually put out a notice. They notified the covered entities that would be impacted. They put the notice up on the Beacon website, which is the platform that they would be using to operationalize the model. And they said, on X date, we're going to start implementing this model. The other 2 actually just jumped right to filing a lawsuit against HRSA. And that's how we found out that they were planning to put forward a rebate model, because they had been working behind the scenes to work with HRSA to maybe get approval. It's not clear if they were actually seeking approval or just giving an FYI. But so it's slightly different starting points for each of these manufacturers from a process perspective, but the end result has been the same for all of them, which is in the case of all 4 manufacturers, HRSA essentially told them, you're not allowed to move forward with implementing this model without our prior approval. And the position the government's taking is that if you look in the 340B statute, it says you, drug manufacturer, are required to enter into an agreement with HHS, with the Secretary of HHS. That agreement's called the PPA, the Pharmaceutical Purchasing Agreement. And that PPA says you are obligated to offer your drugs to covered entities at no more than the 340B price. And the statute says when offering the drug at no more than the 340B price, you can take into account rebates or discounts as provided by the Secretary. And so the position the government has taken is that language means something. And when it says as provided by the Secretary, that means manufacturers can only offer 340B pricing through a rebate mechanism if the Secretary provides prior approval. And in the case of these 4 manufacturer proposals, HHS has not given approval, therefore they may not proceed. And HHS actually even went a step further. They threatened enforcement action. They said, if you move forward with proceeding, we're going to take a couple of different actions against you, or we may take a couple of different actions against you. One is one that we've seen commonly over the last few years. We saw HHS threaten manufacturers with this penalty with respect to their contract pharmacy restrictions that they've been implementing, where HHS has the authority under the 340B law to impose a civil monetary penalty against a manufacturer if they knowingly and intentionally overcharge a covered entity. So that's one potential threat that they put on the table. But in the past, that's really not been enough to scare off manufacturers. And so this time, for the first time, really, we saw HHS go a step further and say there's another potential penalty on the table. And that is we can terminate your PPA. If we think you're in violation of the statutory requirements, we can terminate your agreement. And that's a really big deal because under other federal healthcare programs, under Medicaid and Medicare Part B, manufacturers can only have their products covered under those programs if they have a PPA in place to offer 340B pricing. So termination of the PPA means that manufacturer is kicked out of Medicaid and Medicare Part B. That's a huge deal. That means they're potentially losing, significant revenue on any of their products getting reimbursed by payers. Prescribers aren't going to use their products, they're going to use other products. Of course, there's also the concern from a patient access perspective, how are they going to get their products? This is a really big deal for manufacturers, and so they backed off. And so for all four of these manufacturers, they said, that's too great of a threat. We're not going to proceed with implementation, at least right now. And instead, we're going to file lawsuits in federal court challenging HRSA's position. We think HRSA's position, saying we're not allowed to proceed without prior approval, is unlawful. And the manufacturers are taking the position that when the statute says you're allowed to take into account rebates or discounts, there's nothing stopping manufacturers from going ahead and implementing a rebate mechanism. And I think some of them have sort of suggested that, yes, maybe HHS could provide whether a rebate discount can or cannot be used, but they have not done so. And so the manufacturer's position is, if you look at the PPA, the agreement that outlines the manufacturer's obligations, it doesn't mention anything about whether a rebate can or cannot be used. So in other words, HHS has been silent on this question. So that's the position manufacturers are taking for why they are allowed to proceed with implementation without prior approval. And so that's the question now before a judge in these cases, which is whose interpretation of the statute is correct, or maybe even the best one. And we're waiting for courts to weigh in on that. And it takes time before we get to a decision in these cases.
Yeah. And like, just to thank you so much for that, because I think having that background is really critical, because I think sometimes in our interactions with broader, audiences and covered entities, they're like, well, how is this even possible? Like, and so having that kind of explanation, a more simplistic explanation, I think is really good. Just to kind of play devil's advocate, I kind of have two questions. Like, with the threat of terminating the PPA, that's such a nuclear option. So, like, I know it's a tool in HHS's tool belt, and it has successfully deterred two of the manufacturers that it's been brought against. But like, what is kind of that long-term, is this just like kicking the can down a little bit for someone to challenge it and say, I don't care, and then have, all the patients be wondering how they're getting their drugs paid for? I mean, it'd be a real mess to patients. And so for me, I look at that and I say, yes, it's an option, but it's very nuclear, right? So do you have any thoughts on that?
Yeah, I mean, it's all total speculation, right? I mean, these are business decisions by drug manufacturers, and I cannot profess to speak for drug manufacturers. And I should note, for anybody on who doesn't know me and my background, I probably should have led with this, but I work with hospitals, I work with covered entities, I work with pharmacies. I spent about 8 years in-house at 340B Health. And then in private practice, I continue to work with the hospitals. I also work with FQHCs and Ryan White clinics and STD entities. Bestberry as a firm also has a large specialty pharmacy practice, and we work with a lot of contract pharmacies, and we work with the vendors that support covered entities and providers. So we pretty much work with everybody in the 340B ecosystem other than drug manufacturers. So I cannot speak for drug manufacturers.
Right.
But if you've got to think, if you're a drug manufacturer and you're considering this potential enforcement action on the table, are you willing to deal with the optics of proceeding with implementation? And if in fact the government moves ahead and actually kicks them out of Medicare or Medicaid, what does that mean then? It's the manufacturer's fault that patients have now lost access to all
Sure.
of these products. Now, would the government actually carry through with that threat? I can't
Right.
speak for the government either. I don't know.
Now, question on the other side, if the manufacturers are arguing that HRSA can give permission for a rebate model and they're not yet, could the HRSA just approve them later? And if they do, is there any response that covered entities can have?
Yeah. So it's a great question, and it's certainly something that I'm keeping an eye out for as we now enter or are about to enter in the next couple of weeks a new presidential administration. Will HHS continue to take the same position under new leadership? We, I think, from a provider perspective, provider community have been really appreciative of the position that HHS has taken so far in terms of not being willing to approve these rebate models. But could HHS take a different position and say, I'm going to approve a rebate model? And there are a few potential concerns there or sort of reasons why you could maybe see a change in position or some sort of movement. One, as I already mentioned, is the change of administration. That's still a TBD as to where new leadership will stand on this issue. The other is there is an intersection between 340B and the new Medicare drug negotiation program that HHS is currently implementing through CMS, through the Centers for Medicare and Medicaid Services. Now, CMS and HRSA are two separate agencies, kind of sister agencies that both report up to HHS. So the HRSA administrator and the CMS administrator both have the same boss, the HHS secretary, but they're kind of in separate silos in many ways. CMS is implementing the negotiation program. And as part of that, they've been tasked with figuring out how to direct manufacturers to provide pharmacies with access to the negotiated price. Under the negotiation program, if a drug is selected for negotiation, there are 10 of them in 2026, the first year of the program that the negotiations will take place. If a pharmacy dispenses one of those 10 selected drugs to a Medicare beneficiary, this is all in Part D, so far at least for the first few years of the program, the pharmacy is going to get paid for that drug at a much lower price. The Part D plan is going to reimburse based on the negotiated price. It's the MFP, the maximum fair price. And so to make sure that the pharmacy is not underwater, the manufacturer has to provide the pharmacy with access to the MFP. In other words, they have to make sure the drug got sold to the pharmacy at no more than the MFP. And the way it seems like manufacturers are going to do that is through back-end rebates. They're going to make the pharmacy buy the drug at the price they would normally pay. And then on the back end, they're going to get a rebate to make it as if they purchased the drug at the MFP. And there's a provision in the Medicare negotiation law that protects manufacturers from offering a 340B price and the MFP on top of it for the same drug. And so the manufacturers have been looking for some sort of mechanism to protect them from that happening. And so if they're providing a rebate on the back end for the MFP, they're saying we need to move 340B to a back end rebate model so we can make sure we're only providing one rebate on the same claim. The manufacturers are saying if we provide 340B pricing on the front end and we don't know on the back end whether it's a 340B claim or not, there's a risk that we will offer the MFP on top of the 340B discount. And so manufacturers have been asking CMS to issue guidance that spells out how they can prevent that duplication. And CMS hasn't really come up with their own mechanism. They've sort of said, we're out of this, kind of figure it out. Providers have certainly shared their thoughts in ways that manufacturers could be protected without harming 340B providers, but CMS hasn't really adopted a lot of those mechanisms either. And so the concern is that manufacturers are going to say to HHS, go ahead and approve these rebate models because it's actually going to help us avoid duplication with the MFP. So that's another reason why we need to watch out for, could HHS approve a rebate model? Because they may want to do so with respect to the negotiation program implementation.
Yeah, I think it's such an interesting question. I mean, they've got so many different irons in the fire that I feel like when I take a step back for it, it's like just kind of a race to the bottom, right? Like when Suzanne and I were at the IG's office, I mean, and this was a while ago now at this point, the world wasn't as complex as it is. Um, the idea was always, how can the government pay the lowest price possible? Like kind of period, right? And so now that we've layered in all these programs, I think that that kind of, divide and conquer way, now they're trying to align them in some way, and we're seeing some of the cracks and seeing how things don't quite work out. So like, I think at the end of the day, this maximum fair price is going to be more like what is the absolute bottom? And I think pharmacies are going to suffer at the end of the day. So we'll see about whether the maximum fair price is successful or how that all looks, but it's kind of messy right now. I did want to, and thank you for that little additional tidbit, because I think that connection of both rebate models and the IRA and why that matters is a big one. I did want to kind of move over to why manufacturers are saying they need this. I mean, the buzzword, I know they say prevent duplicate discounts. I would say that on the retail side, for both in-house and contract pharmacies, we have been doing the external audits for everybody on this phone or on this call for probably, I'd say, an average of 4 or 5 years. Excuse me. Some are 10, some are like, the last year. It's pretty hard for us to find things that we would identify as duplicate discounts. There might be new managed care plans that come on that are new that you found within the last 3 months, or there could be issues on the medical claims, secondary payer, or some out of state stuff, but really it's in the margins, right? I would say that this idea of duplicate discounts from what covered entities feel they're responsible for based off the statute is not the real issue here. And I know we've been talking about this for a while, but I want to make sure everyone on the line understands this, that like, it is upsetting when you start to read that there's like no oversight. You guys are, busting your humps trying to prevent duplicate discounts, but they're really concerned about the duplicate stacked rebate payments that they're paying to PBMs. And so that's really what they're trying to say. I've had conversations again with several, the Calderos and BRG stakeholders, and I've said, what will be the order of operations? They say they're going to pay 340B rebates first, but I will believe it when I see it, instead of prioritizing PBM rebates. Just kind of a couple other things you guys, Jeff already talked about the last bullet point on the slide, but there's this, and I'll let Jeff or Suzanne comment on this, but this idea of transparency is like the buzzword. I'm like, what does that mean? And for some drug manufacturers, when you ask them, why do you need this? And they're like, there's just too much money under this program now. It's just too much money. That's like, okay. I don't know that that's the right answer, because there are mechanisms in place to already work for this. And now you're creating another thing. It's almost like, like I don't like the current way I'm looking at something. So I'm going to invent something new, but it actually isn't really making anything better, right? I think it's going to cause the same kinds of headaches and introduce new headaches. But I don't know, Suzanne, I know you like the patient versus entity messaging. I don't know if there's something you want to say on that. I'm going to put it on you, and then we'll let Jeff talk.
Yeah, I think it always becomes hard the more we talk about 340B tying specifically to the patient. I just think in big picture, that's how we end up with, I think it's easy for Congress to be like, great, then why shouldn't the patient always pay the 340B price? In which case the program doesn't work if everybody's just reimbursing at the 340B price, because it doesn't work. The idea is the program reduces costs and the money goes to covered entities, and it's a broader piece. So,
Yeah, I certainly agree with that. I mean, there's a lot of misinformation out there about is the purpose of the program intended to benefit the provider versus the patient. And so that's where advocacy comes into play. We got a new Congress, we have new lawmakers making sure they understand, how Congress always intended the mechanism to work. I'll also add in terms of, what is it manufacturers are really trying to achieve here? So a couple of thoughts to add on. One, on the duplicate discount question, I do think it is worth just like it is what it is. Let's call it what it is. The manufacturers do care about the commercial PBM duplicate discounts. And, I'm putting that in quotes because from a provider perspective, we're like, well, the only duplicate discounts that manufacturers are protected against under federal law are Medicaid duplicate discounts.
Right.
So everything else is not a duplicate discount. But I do think it is important for us from a provider perspective to understand what the manufacturer's perspective on this is. And they do genuinely believe they are being subjected to duplicate discounts because they enter into contracts with PBMs in order to get their drugs on the PBM's formulary. And in return, they say they will pay a rebate to the PBM. But those contracts may say, we will not pay rebates to you on 340B claims. And as we know, the reality is there aren't mechanisms to identify 340B claims. So what's probably happening is that the PBM is invoicing the manufacturer for all of their claims that they pay, including 340B, and the manufacturer is paying both a 340B discount and a commercial rebate on the same claim. Now, they're not protected against that under federal law, and it's not the covered entity's responsibility to protect the manufacturer from that type of duplicate discount. So I do think it's very disingenuous for a manufacturer to sort of put the blame on this type of duplicate discount at the hands of covered entities. But that is the challenge that they're facing. And so I think maybe part of this is so that they can identify 340B claims on the back end and say, we will pay one, but not both. Now, to your point, Madeline, we would hope that they pay the 340B rebate and not the PBM rebate, but that's a little bit of a TBD. But beyond that, there is another really big motivation, I think, and this is just my personal perspective here. But let's just put this all in context in terms of the timeline and sequence of events. Drug manufacturers for years have been lobbying Congress and HHS to shrink the program. Congress to date has not passed legislation that would make meaningful or significant or any changes to 340B that would shrink it. HHS has not. They attempted to issue first mega regulations, then mega guidance. This was back in 2015 that would have narrowed the definition of a 340B eligible patient and ultimately did not. And so in 2020, manufacturers started taking it into their own hands and unilaterally imposing contract pharmacy restrictions. This was their effort to shrink the volume of prescriptions that they have to offer 340B pricing on. And we're now 4 years in, and I'm not sure the manufacturers feel like those restrictions have worked or have not accomplished their goal of really dramatically shrinking the program. And I think there are a number of reasons for that, right? We know that there have been mechanisms that entities have been able to use to help them mitigate the impact. Alternative distribution models, alternative replenishment models. We've also seen changes to patient definition policies in light of the Genesis lawsuit and changes in HRSA's audit enforcement. Although I'll note we're seeing some shifts back in HRSA's audit enforcement, so should all be paying attention to whether changes in patient definition perhaps should be reevaluated. So that is something that I have been working on with clients in terms of, what is our patient definition policy today? Have we made changes in recent years? Will it sort of stand up to HRSA scrutiny moving forward? That's an aside. But because of these mechanisms, these actions that covered entities have taken, it seems like manufacturers have felt like our restrictions have not worked. We need to try something new. And so now we're going to go try 340B rebates. And that's going to go after alternative distribution models, ADM, because they are saying that you have to identify for us the NPI of the dispensing pharmacy. And they're going to reject the 340B rebate if the pharmacy that dispensed the drug is not one of the approved designated pharmacy locations. And they are also, I think, in some of them, not all of these manufacturers, but at least one of them, Sanofi, is going after patient definition. They are saying, we want you to submit encounter data to us so we can validate for ourselves whether we think this claim was for a 340B eligible patient. And I think we can all safely assume that the interpretation of patient eligibility that a manufacturer is going to use is going to be narrower than the interpretation of patient definition that you or even HRSA uses. This is another example of manufacturers just taking the matter into their own hands and unilaterally saying, we're going to police the program. We're going to decide if this is a 340B eligible prescription. And if we don't think it is, based on the claims data you've submitted, we're going to deny it. So this is not just, in terms of motivation, this is not just we're going to change the way you get access to 340B pricing. I think it goes more than that. I think it's a part of their overall effort to try to shrink the number of prescriptions that qualify for 340B pricing.
Yeah. Well put.
Yeah, I was going to say, I wonder if part of that, and you mentioned that different manufacturers have different interests, has to even do with what their philosophy and how they've worked, right? So if you're a manufacturer that has really given very large discounts, commercial discounts, like rebates on the back end, that might be where you're losing more money versus extra on patient definition, versus someone who maybe doesn't need to have those commercial rebates to be on the formulary, but is seeing then losing money from more prescriptions from patient definition. I guess that goes back to, I assume it's all math, and that the manufacturers have very complicated and sophisticated algorithms to figure out what matters the most to them.
No doubt about it. I mean, you look at one manufacturer and you've looked at one manufacturer, right? Each of their portfolios is different and their exposure is different. And so if you're the type of manufacturer that has a ton of drugs being dispensed through mail order specialty pharmacies, well, they're set up as contract pharmacies, right? They're going to want to go after ADM. If you are the type of manufacturer that has really big 340B exposure for drugs that are often written in specialty clinics that are not hospital based, but maybe they're qualifying through referrals, maybe you want to go after patient definition, right? And I do think it's also important to think about that too, not just when it comes to like these different types of restrictions that are being floated or implemented, but also when we talk about legislation and Congress and efforts to reform the program, because not all manufacturers want the same kinds of reforms. Some manufacturers are more concerned about contract pharmacy reform. Other manufacturers, their portfolio is all administered products in hospital clinic settings, and they want to go after patient eligibility, and they want to go after changes to child side eligibility. They may not care as much about contract pharmacy. So I do think thinking about these different manufacturers individually is important.
Totally. Totally. So, and then Fern, I see that you made a comment in the chat, just, kind of getting to this point exactly about you're having a conversation with one manufacturer and what they're concerned with versus someone else, right? But I think this idea of there's too much money out there, it's too big of the piece of the pie. It's so funny. I did interviews with 10 manufacturers in 2003. This is a long time ago. I did a little drive tour. I drove through New Jersey and I stopped at about 10 different manufacturers. And the conversation is so wildly different because it's like they had to find someone for me to talk to, first of all. And they had to have someone that was like, and they kind of handled it differently to this point of like, all manufacturers are different. J&J had like 20 lawyers in the room and it was just like little old me. And I don't know. I was like, I'm just here to talk about 340B. But we were trying to collect information about market size and what their like, pain points were for the program. And it's just so wildly different. It was like, I don't know, it's under 1% or it's under 5% of our total expenditure. So, we don't really care. Not that they didn't care, but just the attitude is just so shifted. And it's, contract pharmacy has been a big contract pharmacy, outpatient shift in general, more hospital-based clinics, the rise of specialty kind of in general, like those are all variables that factor into this. So it's not just one thing. They did want to kind of shift a little bit more and then talk about like what are some of the covered entities concerns. I know that we're talking to covered entities, so you probably have thought about all these things, but I think it's just good in this kind of venue to make sure that we're all kind of on the same page.
Yeah,
Jeff?
I mean, we put some here and I'm sure these are going to look familiar to everyone on the line because, you've been putting thought into this, but, this is what I've been certainly recommending my clients do in terms of, we're in a bit of a pause right now, but,
Yeah.
we have to see what happens with these court decisions. Will they allow these rebate models to move forward? Will HHS change its position, allow rebate models to move forward? So we need to be prepared for this. And also, I think it's important to go through this exercise and sort of gather the information for the advocacy purposes, right? Whether that be educating HHS on why they should not budge and not allow the rebate models. Congress may need to be educated on this. There's certainly talk about hospitals intervening to join the lawsuits. So that may be a need to be able to gather this information to be able to help kind of defend the government's position on this. Cash flow is obviously a key one. I mean, at the end of the day, we always talk about operational burden, and I do think it's incredibly important to gather specific examples of the human capital expenditures that you're going to have to incur to be able to submit all the required data. Definitely collect it. I will say from an advocacy perspective, that's not always the most persuasive, argument for why, this should not move forward. But the financial ones I think are really, really significant. So cash flow, like you're gonna have to buy these really, really, really expensive drugs at whack and hold that cost until hopefully eventually you get the rebate. Now, one thing that I think is worth putting some thought into is some of the manufacturers are arguing or trying to sort of adopt elements to their policies to say, we hear you on that and we're sympathetic. And we're going to make sure the way we implement this rebate model is going to prevent you from having to deal with cash flow issues. So like one of them said, if you submit the request within 22 days of, I believe it's the WAC purchase, then we will make sure we honor the rebate request within 30 days. And they say, well, your commercial contract terms say your invoices to wholesalers are due within 30 days. So as long as you get the rebate from us within 30 days, then you'll be able to, get that money before you have to pay your invoice. You won't have any cash flow issues. But I've been hearing that there are a number of flaws with that line of thinking. One being you might have a prompt pay arrangement with your wholesaler where you're required to pay within 14 days.
Yeah.
Another is that you buy your drug and it might sit on your shelf for a long period of time before you actually dispense it. And then it was 340B eligible, and then you need to submit the rebate request. So it may be impossible for you to submit the rebate request within 22 days of the drug's purchase. So I think there are a lot of reasons to doubt whether these sort of elements of the manufacturer policy is intended to address cash flow issues would actually work. So I think it's important to be able to gather examples of why the manufacturers are wrong, and you would, in fact, be facing cash flow issues. The reduced savings is the bigger probably financial impact here, which is how much exposure do you have in terms of ADM, referrals, expanded patient definition policies, things that you think would go away. Now, this is a tricky one in terms of like sharing sort of publicly examples of ways you're using 340B that you think manufacturers would take away from you. But at least for internal planning purposes, it's important to be aware what the stakes are here, because this is not just about operational burden. It's really about bottom line and, taking away 340B savings. And the Medicaid billing requirement seems like it's like an administrative one, but this is actually probably a lot bigger of a deal than it sounds. If your state or your MCOs require you to identify on the claim whether it was a 340B drug, how do you know at the point of billing whether to include the modifier if you don't know whether you're going to get the rebate paid or not? It's not really a 340B purchase until you get the rebate. So how does that work? We don't know.
And I think that is for me, that Medicaid piece, we already have problems with retroactive Medicaid billing and eligibility. We already have issues with Medicaid as secondary when you need to put on the modifiers. I mean, there's already problems with perfection as is. In a rebate model, it's gonna, I can only see this being magnified, where you're waiting around and trying to figure out like, okay, how do we fix this? And so I just think in general, like it's just, it changes a lot about the lift that hospitals have taken to build their charge master or to build their coding for identifying. It would be a complete like a really big shift.
Just
If you
out of
yeah, go ahead, Suzanne.
this is just out of another, as we're thinking about this rebate model and the purchase and what all that means in contract pharmacy on that side, right? So I know of two off the top of my head, like chains that require a wholesaler rebate credit model, right? So like Walmart and Meijer. How would that even work in this piece of submitting claims? Because now we have a TPA and the wholesaler involved, and then you'd be submitting that data. I don't know, it just blows my mind.
Yeah, well, I think what you're really raising is an existential, theoretical, make your head hurt kind of question where it's like, what is really the end result here? And this is something Madeline and I have talked about, is like, does this just get rid of the inventory management model and require separate inventories? Because if you look at some of these policies, and I should note, this is a caveat, they're not all very clear. They've not gone
Right.
into super great detail. A
Yeah.
lot of these terms are not defined, and the devil is very much in the details. But we're just thinking through, we're brainstorming here potential consequences of these types of rebate models. And one of them is that in some cases, it sounds like what the manufacturers are really trying to do is to force you to tie a purchase to a dispense in that order of operations. Like you
Yeah.
first buy the drug, and then you
Yes.
track that drug, and then you see which patient that specific physical drug goes to, and
Yes.
then you can submit the rebate request. And you see in the required data elements, you have to submit the invoice. They want to see the purchase information. I don't think they're asking about purchase information for a replenishment product.
No, they're not.
I'm worried that they're asking for purchase information about the original product that hit your shelf that then went to that specific patient. And if that's what they're asking for, I don't know how you do that other than by either maintaining a physically separate inventory or having a really sophisticated barcode scanning system where you can track individual drugs through the whole process. And does that then call into question the whole ability to use contract pharmacies? Because no contract pharmacy is going to use, well, with the exception of some small independents, they're not going to do physically separate inventories. So, I don't know if that's where this is going, but that is a concern I have.
Yeah.
Well, wasn't Sanofi one of the manufacturers, and they're very concerned about replenishment, like philosophically, like they're like that replenishment is
Yeah, they have
not
made the
titled to the
argument
drug.
in court that the concept of a replenishment model is unlawful because by definition it involves covered entity transferring title of a 340B drug to an external pharmacy that's owned by a separate legal entity, and that unto itself constitutes diversion. And so yes, they are calling into question the entire legality of using a virtual inventory model in a contract pharmacy setting.
Right. Which is funny because other manufacturers are making other arguments around this whole kind of replenishment question, right? And so there's lots of documentation, like even Astra, like it might seem innocuous, but a couple months ago they were like, hey, we know that when we change the NDC on this product that you're not able to replenish based on your old accumulation, so we're going to let you replenish on this new NDC. So like those kinds of little things I think are going to be used as evidence that manufacturers have recognized replenishment. I know that seems like a little thing, but it's not. But as far as some other operational concerns here, I mean, I know that. Oh, can everyone make sure they're muted? I'm sorry.
He didn't say Sunday service, he said Sunday.
Sorry. Okay. Anyway, what I was going to say is that there's some kind of bigger questions that, again, Jeff said this really, you don't have to mute yourself, Jeff.
There's thrilling going on, so I did.
That there's a lot of challenges here, and this again, these are the kinds of things that we want you to think about, and if there's ways to quantify it, like for example, when ESP came out, thinking about like the time it took staff or the time that you had to contract that out, or who is doing that for ESP, and thinking about that in a similar fashion with these requirements. There's also two different platforms. There's BRG and there's Truzos. Is that what Beacon and Truzos, Calderos and BRG, that they're not doing the same thing. So like, for example, we can see from the policy documentation that that BRG/Beacon is going to do this, kind of reaccumulation. We will pay you your rebate once you've reached full package size. On the Caldero side, all we know right now is from Lilly, and Lilly they haven't said this publicly, but just in conversations that we've had with Calderos, they said, well, we're going to do a per unit rebate, which I'm like, I don't even know. That kind of blows my mind altogether. Even though I know that's how Medicaid works, Medicaid also weights and aggregates all of that unit information after a quarter. So this is not the same sort of thing. So that kind of like ongoing, like kind of, I think about it like almost like pennies in a piggy bank instead of, waiting till you get, you're not taking like your whatever. I'm mixing up 10 different analogies here, but it's going to be really difficult to suddenly go to a per unit rebate rather than a full package size. I know we've talked about retroactive Medicaid, the bespoke requirements. I'm just worried more about like, are we going to have, there's 500 plus manufacturers in the program. I know that sounds wild to be like there'd be 500 different requirements at some point, but like even if there's 10 different requirements, that's still a lot for covered entities to manage. Right now there's a big discussion about like, well, like at least for J&J, they're like, here are the two drugs. It's just these two drugs, but it's like, no, there's already guidelines in Beacon platform about administered meds. And so I don't know, Jeff and Suzanne, if you want to talk about kind of bullet point number 1 with like the separately paid issue.
I'll just say, I think it's very sneaky. And I think that you have to kind of go through and really read what the Beacon documentation is saying. I don't think they're going to come out and say anything directly, or at least right now, we don't have much to go on other than what's kind of in these larger welcome packets. But I would encourage everyone to go through and read them with an eye towards, hey, they specifically say outpatient separately billed. Okay, what does that mean, and how is that different than how we may use 340B right now?
Yeah, and I just think a sort of a broader kind of umbrella point to make here is what we should all be doing right now as part of our homework is thinking through, if we ended up having to submit all of this required claim data, how could the manufacturers use it to potentially justify denying the rebate requests? And there are a lot of unknowns, as Suzanne said, because we're going off of, 2 of the manufacturers have policy documents, the other 2 do not. And then there's sort of general information on the Beacon website, but you don't necessarily know if it applies to each manufacturer. None of these requirements, none of these policies are in place. So it is theoretical. But there are certainly concerns. We know in past years, there have been manufacturers that have taken the position that if a drug is paid as part of a bundled rate, then it's not a covered outpatient drug, and therefore they do not have to offer 340B pricing for it. So I think it's rational to ask the question, could a manufacturer use the information we submit with this claims data to come to their own conclusion based on their own definition of what is a covered outpatient drug, that this drug is not a covered outpatient drug, and therefore they're able to deny the rebate request? I mean, the list goes on in terms of the ways, the power that this model would be giving to manufacturers is so great. There are so many ways that they could use it to control their liabilities and deny 340B pricing.
Yeah, and exactly to that point, this idea, if I were in a covered entity shoes, I would be pushing this as my number 1 point. Data sharing, privacy concerns, not just about the deniability of a rebate, which I think that's a totally like great point, Jeff, but also like in an era of all this data sharing and different privacy rules, if all of this information starts getting sent up, what does that mean? Are you going to start you know, I know they keep saying they're going to de-identify and this and that, but there's ways that, you know, we all say we accept the Facebook or Instagram or TikTok privacy rules, and then we're wondering why I'm going to get, you know, some sort of you know, ad that's targeted just to me, right? So like I think about that with like, are patients going to suddenly start getting information or start getting ads about like, we see that you're not thriving on this medication. Do you want this? I know that sounds crazy, but it's not so crazy, right? Our doctors, our prescribers going to start getting like, did you know that this is more effective? Did you know that if you move to this combination therapy, that it's going to serve this, you know, maybe it's not targeted specifically, but this kind of I know I sound like I should have a tinfoil hat on, but I'm married to a privacy attorney, and I think everybody knows that. But like data is very powerful, and the resale of that data is not prohibited per Beacon's contract terms. Like they say they can do whatever they want with the data. So that's my concern. So if I were advocating, I would be digging in hard on patient privacy, hospital privacy, what would happen if there was a breach? Because according to the contract, which also gets into this one-sided, if there's a breach, you're on your own. Like they're not accepting any liability for it. So I would really be, you know, aside from all the arguments that we're talking about today, I would really be talking about kind of these contract terms. They're very draconian, and I would also be talking about privacy. Um, it's
And
just really important.
and I'll just add from a legal perspective, the Beacon platform and the information that might be submitted through it is different than the ESP platform and the information you may already be submitting through ESP. So even though you may have worked with legal, whether internally and or externally, and came to the conclusion you were comfortable with the ESP terms and those data submissions, does not necessarily mean you would come to the same conclusion for Beacon. And just to give you one example, at least one of the manufacturers is requiring not just you know, the claims data for you know, the actual dispense, but they're also asking for the encounter data because they're going to use that to validate patient eligibility. So they're asking for things like the actual date of service when the patient was seen at the hospital and who the rendering provider was. I mean, this is PHI, right? Like this is more information than
Yep.
what you are submitting currently to ESP. So I do think it makes sense to go through that analysis, work with counsel to evaluate, you know, how does this go further than what ESP already is doing? And
Yep.
not just for internal compliance purposes, which is first and foremost, but then also to support your advocacy so you can be able to explain why this is even worse.
Right. Right. Yeah. And I think that you know, we have some next steps. I think we've talked about a lot of this, but I want to make sure that if there's any questions from the crew. I know that Casey, you had asked a question about like kind of the long term, you know, if you're looking at what your acquisition price is and you're not able to afford it kind of on the front end. Yeah, I mean, I do think that is um there have been a lot of studies that are kind of getting at, do 340B providers change how they prescribe things based off the margin they can get, right? And I don't think that that's part of it, but I do think that your question, which is the inverse, could be a possibility where it's like, oof, we can't, you know, this drug, we're going to be under, you know, we're not trying to optimize reimbursement, but we're going to be under. And so I think, and there's no chance on the other side of making it up, right? Like 340B to me is always this kind of like, the way I explain it to like, you know, my parents is always like, 340B lowers costs for the institution because they're going to get paid wildly different prices from all their different patients, right? And if all their patients are underpaying, what happens, right? So, And that would be an elevator speech. You don't need, it might be more eloquent and maybe less raspy, but that's how I always explain it. And so I think that kind of combined with some of the things we've talked about today, I mean, I think that I know no one wants to really stick their neck out, but having some better examples of what the hit looks like. And, Casey, that is a really good example, right? Um, those kinds of stories are much more impactful to our legislators than coming in and being like, I mean, not that anyone comes in and is like, we just don't like this, but there needs to be some like bullet points that are super concrete around this. And like Fern, to your point, if the state is telling you that they're going to do a forced carve out in order to comply with this, it's going to make your budget go up. So looking at, okay, what is our Medicaid payer mix? What does it mean then if we totally carve them out? How do our costs change? Right? So it's that whack-a-mole kind of idea, but you need to, for everyone involved in this, that is a reality of having the state then dictate what they expect, and then you having to say, okay, but then here's what it's going to look like for us.
I would echo that and add that it's really important to have really those concrete examples of how these types of manufacturer policies would harm your specific institution and your patients. Because I do think there is this danger or risk of, the boy who cried wolf, right? Like 340B providers are always saying, if we get hit with these cuts, it's going to harm us. But then, like, does the harm actually happen? And we know that, when those Medicare payment cuts were in effect from 2018 to 2022, almost 2023, there was real harm from that. But, without articulating it with specific examples, it can come across as though it's just this money grab. And when the money goes away, you figure out ways to make it work. But I think these are two really great examples that could be put on paper to show the real concrete impact. On the chemo example, I think what you were alluding to, Madeline, is that, a number of years ago now, and this was back in 2015, the GAO, the Government Accountability Office, came out with a report that they thought was going to be this sort of doomsday for 340B because it made it look so bad. It said 340B hospitals are spending more on drugs and using more expensive drugs as compared to non-340B hospitals, and then that was costing Medicare money. And so a lot of program critics have pointed to that as evidence that there's abuse, that 340B is some sort of financial incentive that's driving 340B hospitals to spend more or use more expensive drugs. But then there's also been a lot of research since then to counter it, to say, hey, guess what? A lot of these hospitals, they're like NCI designated cancer centers, they're academic medical centers. They are providing those incredibly high cost specialty drugs that other providers aren't able to afford. But because of the 340B margins, these hospitals are actually able to use those drugs. So if the answer is, if you're unable to use 340B, that makes you look more like the non-340B hospital, and then you'll have to go back to not being able to use that product, and that's going to harm patient care and access to care. I think that's a great example.
Yeah, totally.
I really appreciate that it's not patient specific and tying it to how much patients pay. Because again, I think we need to move away from that as an industry, as that being the only example of patient access is reduced cost. Because 340
Right.
helps in so many other ways than that one-to-one relationship.
Right. Yeah. Yeah. It's about like what you have access to as an institution and the kinds of decisions institutionally, like your P&T committee, like what kinds of things they have to do. It's not so much based off of, this one person needs this expensive. They could go either drug A or drug B, and I'm going to do the one that has the most margin. I don't know anyone who runs their business that way. Um, but, having those concrete examples are really important. We have 2 minutes left. Is there anything from the audience that we haven't addressed?
We just did such a good job talking about it.
It go by, yeah. Well, I really want to thank Jeff for this. Jeff, thank you so much. I should have done a more proper formal introduction, but I was like, everybody knows Jeff.
I was
And
looking at the list on who's on, and I recognize a lot of names, so I do hope most of you know me. But if you don't, please feel free to reach out. I'm sure Madeline and Suzanne can share my contact information. And I would happily set up a time to chat just to connect and see if I can be helpful.
Absolutely. And this will also be recorded and put up on Next Level. And for anyone who wasn't able to participate live, Suzanne, you were going to say something else?
No, I was just going to ask Jeff as like a closing question. What do you recommend that covered entities should be doing right now? Should they be, reviewing the contract terms? Should they I don't, from your perspective as an attorney?
Yeah, I think you could say, and I'll try to keep this quick, three things. One, preparing for if this happens, are you ready to comply? What does that mean for you? So that means working with legal to review the terms. Is this something you're in a position to be able to do operationally? Is it something you're in a position to do? Two is go through that exercise, but through a different lens, which is more for supporting advocacy, which is what's going to be the impact if we have to do this? How is it going to be problematic for us financially, operationally, so you can support your advocacy, whether it's with HHS, with Congress? And three, there is a legal process ongoing here in the courts, and there are opportunities that are being discussed about intervening. Whether it's, like the 340B Health has said that they're considering that. And so, thinking about whether that's something that you'd want to do. But I'd say those are the sort of three things that you can be doing rather than just sitting on the sidelines and hoping this does not happen.
That's really good. And then one last question, thoughts on the political landscape related to the rebate models? Jeff?
Yeah, I mean, HHS is a little bit of a wild card because we've got not a whole bench yet approved and confirmed. We haven't even had an inauguration. I don't think RFK Jr. knows much about what 340B is, or maybe Dr. Oz. So we need to see who else is sort of staffing the agencies in terms of what HHS's position will be on rebates. And then there's Congress, and you could imagine rebates getting sort of caught up in the discussion on the Hill. We do think there's going to be an elevated interest in 340B in the new Congress. The new chairman of the Senate Help Committee, Senator Cassidy from Louisiana, has been a very long time, strong, staunch critic of the 340B program. He's been conducting an investigation into 340B. I expect that will continue. I expect he'll want to hold hearings. He will likely want to consider legislation. But it is not a sure thing that just because he's in that position and that Republicans control all three branches, that there will be 340B reform legislation. John Thune, the new Senate Majority Leader, senator from South Dakota, longtime supporter of 340B hospitals in his state. And at the end of the day, I think most of the big, comprehensive, major 340B reform issues would require 60 votes in the Senate, which means, bipartisan compromise. And I think that's still an uphill battle to be able to get to that kind of consensus. So I think that there's hope that that kind of major comprehensive massive 340B reform would not happen. But it's going to be a very busy year for 340B. And I think that's the only thing we can say with certainty.
Can I ask one more question? And I know we're over time now, but my last question is the state contract pharmacy laws. Do those impact the rebates, or do you see that impacting contract pharmacy rebate programs?
Probably not, because the number one key legal issue at stake with those laws has been whether or not they're preempted by federal law, whether the state laws, when manufacturers have been trying to challenge those state laws in court, they've been arguing federal law preempts the state law. And most of the states have been successful so far in court, with the exception of West Virginia, to argue that no, the federal law 340B is about pricing, but the state law is about delivery. And that's two separate things. So this state law can stand. But that also means that these state laws are probably not going to be helpful to stop rebate models, because rebate models are about pricing. And so
Right.
pricing is what's regulated at the federal level. So I don't think that the state laws are really going to speak to a manufacturer's ability to offer 340B pricing through a rebate or not. The state laws are about whether manufacturers are able to interfere with the delivery of drugs.
Interesting. All right. Thank you. I know that was like last minute.
Yeah, absolutely.
Okay, and any other follow-up that anyone wants to have, you can ping us anytime. But Jeff, thanks a ton.
Yep.
As always, this has been a great discussion. Appreciate your time and have a great Friday, everybody.
Thanks for having me.
Bye.